Hello, everyone, and welcome to our webinar today on improving access to palliative care, interdisciplinary approaches to ease serious health-related suffering. My name is Nazli Abedini. I will be your moderator for today. I'm a clinical fellow in palliative medicine at the University of California, San Francisco, and I'm the current chair of a new CUGH working group on palliative care. I'm joined today by our speakers, Billy Rosa, who is a Robert Wood Johnson Future of Nursing Scholar and a PhD candidate at the University of Pennsylvania School of Nursing, as well as Christian Ntizimira, who's the city manager at the Kigali City Cancer Challenge Foundation and a former executive secretary of the Rwanda Palliative Care and Hospice Organization. We're thrilled to have these experts with us today. And before we get into our objectives, I'd just like to remind our listeners that we will be having a Q&A at the end of this session, and please feel free to send in your questions as we go along. So our objectives today, we will first define palliative care, since I recognize this may be a new term for many of you, and then we will discuss gaps and opportunities for palliative care capacity building and development globally based on the findings of a recent Lancet Commission report on this topic. And then we'll spend the majority of our time today exploring examples of interventions in sub-Saharan Africa to improve palliative care capacity and to integrate palliative care within health systems. And specifically, we'll look at how to engage with local populations and also how to leverage interdisciplinary and nursing support in this work. So I'll start with the introduction to palliative care. The International Association for Hospice and Palliative Care recently came up with a consensus definition of palliative care. Palliative care is the active, holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life of patients, families, and their caregivers. And serious health-related suffering is a very important concept for us to consider. So there are two components to this. Suffering is health-related when it is associated with illness or injury of any kind, and health-related suffering is considered serious when it cannot be relieved without professional intervention and when it compromises physical, social, spiritual, and/or emotional functioning, which we'll come back to that latter point. And severe illness is defined as any acute or chronic illness and/or condition that causes significant impairment, and it may lead to long-term impairment, disability, and/or death. This concept of palliative care has its roots in a concept called total pain, which basically states that pain is something that is more than just physical experience. It actually can comprise social, spiritual, and psychological suffering. And in order to alleviate pain, we must address all four of these domains. Additionally, an important concept to keep in mind about palliative care is that it can be delivered concurrent with disease-modifying therapies. Many people think of palliative care as something that's distinctly delivered at the end of life, but that's actually not true. And it's something that can be started at the beginning of a diagnosis with a serious illness and should be continued and ramped up as someone goes through their illness and as they approach death, and even after death in terms of bereavement care. So really something that people need throughout the continuum of their disease experience. And just a couple of other important points about palliative care. It's explicitly been recognized under the human right to health by the WHO and other entities. There's really been a call to integrate the palliative care within health systems as part of universal health coverage and primary care, and even is considered to be an important part of achieving Sustainable Development Goal 3.8. There's a huge focus on interdisciplinary care delivery, which I know Billy is going to touch on in his talk. And it's required for a wide range of diseases and prognoses. And as I mentioned, it's not just about delivering it at the end of life, but throughout the continuum of a disease process. I'd now like to transition to talking about the actual gaps in palliative care on a global level. I mentioned there's been a huge undertaking by a Lancet Commission on palliative care and pain relief to quantify the degree of burden globally. And I've included a couple of links here for you to access the articles. And we'll go through just a few of the key findings just to get on the same page around this issue. So the Lancet Commission report estimated that in 2015, 25.5 million people experienced serious health-related suffering prior to death, and that's 45% of all global deaths. In addition, the overall burden of serious health-related suffering among the living is estimated to be more than 61 million people worldwide. And as you can imagine, with increased life expectancy, we also project the serious health-related suffering is going to increase, particularly as we see increases in dementia, debility, cancer, and chronic disease, which currently account for more than 75% of all deaths in low and middle income countries. In addition, the Lancet Commission report found that greater than 80% of people living with serious health-related suffering are from low and middle income countries, which demonstrated a tremendous chasm in access to palliative care and pain relief globally. And in low and middle income countries, children actually account for greater than 30% of all deaths associated with serious health-related suffering, which can be compared to less than 1% of deaths amongst children in high-income countries. So huge disparities and opportunities for palliative care. The Lancet report also called for a low-cost essential package of medicines to be made universally available to relieve serious health-related suffering. And they emphasized universal access to immediate release morphine as a major component of this. And just to give you a reason as to why this is important, the proportion of individuals experiencing moderate to severe pain lasting more than 90 days globally amongst cancer patients, it's 80%. Cardiovascular and chronic lung disease, 67%, and in HIV and AIDS, 50% of patients are burdened by this type of pain. Additionally, the Lancet Commission report demonstrated profound gaps in opioid access globally, particularly in low and middle income countries. And they estimated that of the 300 metric tons of opioids distributed worldwide each year, only 0.1 metric tons or 0.03% were distributed to low-income countries. And the poorest individuals received less than 2% of necessary opioids to relieve serious health-related suffering. We won't have time to talk about all the findings from the report, but a really important message was that we must integrate palliative care within health systems through universal health coverage to ensure that patients have access to appropriate palliative care and pain relief. And this was thought to actually be an important part of strengthening the overall performance of health systems. It's thought to be really helpful in reducing the risk of catastrophic healthcare expenditures, which are a major cause of impoverishment in low and middle income countries, and that there are potential cost savings for health systems in low and middle income countries by reducing end-of-life hospital admissions and costs. So just a quick overview for you to give you a background. If you'd like to learn more about the findings from the Lancet Commission report, I've provided the link again here, as well as if you'd like to dive in into more detail around global palliative care, I've also provided a course for you on the International Association for Hospice and Palliative Care. And with that, I will turn it over to my colleague, Billy Rosa.
So thank you to Nazli for a wonderful background and introduction. I'm going to really be focusing on how we can come together as interdisciplinary teams to really optimize palliative care delivery within our healthcare workforce and the system at large. And I'm going to be offering a little more breadth through 3 individual case studies in Liberia, Rwanda, and Botswana. And then Dr. Christian Natizamira is going to dive a little deeper into one of those case studies with regards to Rwanda. And so I want to start by something that may sound somewhat pedantic, and I really don't mean it to. But one of the first steps is to really identify who our multidisciplinary stakeholders are. So you can see a long list of colleagues here, but palliative care is inherently an interdisciplinary specialty. And so one of the things it does, it challenges the traditional hierarchies within the medical model that so many of us are used to working within. So for instance, we really want to leverage the skills, the talents, the contributions of every available team member, not only through task shifting, but also really understanding what their training background and abilities are. And this is really important, particularly in low resource settings. So for example, I have APRNs and PAs on the slide, and I have to tell you as a nurse practitioner myself, that I meet a lot of colleagues who don't fully understand what nurse practitioners' scope of practice actually is and how they can contribute to universal health coverage and universal palliative care access, or how physician assistants might increase their autonomy to deliver care services, particularly in underserved areas. We also need to be able to identify stakeholders outside of the traditional clinical family, so also policymakers and institutional leadership, because without their input and advocacy, we won't become integrated into health systems and be able to deliver palliative care services in the way we hope to. We really just end up talking amongst ourselves. In a recent, upcoming rather, Lancet Global Health Commentary, colleagues and I really addressed 4 things that we can do to optimize the interdisciplinary workforce. And we are speaking in this commentary predominantly from a nursing perspective, as that's my lens, and it is the WHO Year of the Nurse and the Midwife. But the first thing that we talk about is how we align our palliative care advocacy with other professional initiatives that are happening. So for example, universal palliative care access in alignment with the International Nursing Now campaign that is actively raising the visibility and the profile of nurses around the world to really ensure that they are seated at policy and decision-making tables around the world. How can we advance the message by linking those 2 sets of goals together? The second is adapting models of education to the cultural, the resource, the practical needs of a number of international settings. So for example, in Uganda, one study, an educational initiative, looked at how enabling nurses with 6 months of advanced training in pain relief and palliative care to prescribe morphine extended the reach of palliative care in the community throughout the country. And then other nurses in Uganda who were just trained in basic palliative care in a major referral hospital were able to better identify patients with palliative care needs and then request palliative care specialty consultation for a greater number of hospitalized patients. Number 3, really building long-term mutually beneficial partnerships based on inclusivity and respect. And there are a lot of key terms in that sentence: long-term, sustained, mutually beneficial for all partners, inclusivity and respect. You may have all heard the quote by Verna Myers that says, "Diversity is being invited to the party, but inclusion is being asked to dance." And so we want our partners, whether in low or high resource settings, to truly feel engaged throughout the partnership that is advancing palliative care delivery. And then the last is full engagement of all team members. So typically we do leverage the talents of team members in the delivery of healthcare, but not always in the planning and in the evaluation phases. And so we want team members, particularly in a palliative care model, to feel seen, heard, and acknowledged to the full extent of their scope of practice. And one way we do this in palliative care sometimes is by rotating who leads rounds, for example. So maybe a social worker will lead rounds one day, a physician or a nurse another day, a chaplain yet another day, to really make sure we're hearing all team members. So I'm going to jump into the case studies, and I'm going to start with one in Liberia through an organization that many of you know, Partners in Health. And I do believe my colleagues from Liberia are on the webinar, so during the Q&A we may be able to hear from them. And this is really a story of just an incredible group of community nurses that really are using all means necessary to provide palliative care to patients in this rural area of southern Liberia in a town called Harper in Maryland County in West Africa. And so this is a group of roughly 10 nurses and 1 physician assistant who are traveling by air, by water, by land, really challenging topography and weather conditions, to alleviate health-related suffering in the context of serious illness. And this program was started about 2 years ago. You can see the team leader, Julius Kapoa, there on the right. And what the nurses were seeing were basically patients' symptoms were not being managed upon discharge from acute care facilities, and they needed a way to really build relationship and foster palliative care delivery in the communities. And I know as of last spring, they had over 50 referrals to their service. And to date, I just heard from Julius the other day, I believe they had just over 30 patients that they have enrolled and cared for under their care. And so my work with them as a nursing advisory board member for Partners in Health started back in 2018. And we started talking about how we could facilitate capacity building for this Liberian community-based team. So the first question was, how do we do this in a country where there really are no reliable palliative care services? There were no models that they could really follow. To our knowledge, there was only one hospice in Monrovia, which was the country's capital, but no palliative care teams in communities and hospitals that team members were aware of. The second was inconsistent access to medications, not just opioids, but other analgesics and symptom management medications. So in the hospitals, there was inconsistent access to IV morphine. In the community, there was irregular access to tramadol. And then there was sparse access to fentanyl for surgical interventions. Some of that was based on the disparities of opioids that Nosley talked about earlier. But even within the country, there was simply no regulatory mechanisms for the flow of narcotics for access at the local level. There was a lot of opiophobia, stigma, misunderstanding about the use of opioids that we had to think about for capacity building purposes. One of the most fascinating conversations was around that of stigma. So there were certain populations, like many other places in the world, where people with HIV or AIDS or members of LGBTQ populations were heavily stigmatized. And so the conversations we had were not about changing that stigma, but rather, how do we hold that stigma in one hand, and on the other hand, really discuss our ethical obligation to provide humanistic, person-centered care for families and communities and build relationships that are ethically relevant to our work and to alleviating suffering. There was a lot of discussion about cultural concerns related to serious illness, death, and dying, about the transparency with which we could talk about these issues, about the role of traditional healers, local healers, and what were the overall service goals. So what was the patient capacity that this team of nurses was going to be able to care for effectively, and how did they see their integration within acute care settings as well as in the community. So we decided to plan a one-week education initiative to start, and we used the LNEC curriculum, known as the End of Life Nursing Education Consortium curriculum. And this has been around since 2000. It grew out of the United States with American-based funding. Some of this data on the slide is the most recently available, but is a little outdated, so that I know that at this point, well over 25,000 nurses in over 100 countries have been trained using LNEC. Close to 1 million nurses and other providers have received LNEC training from certified trainers. And so the strength of this curriculum is that it is a train the trainer curriculum. So these nurses could undergo this training and then select particular modules to go out and train other community health workers and nurses and physicians in various contexts in Liberia. A great opportunity was to take this curriculum and adapt it to the Liberian context, which was so important. So we got to talk about palliative care philosophy and really talk about the Liberian culture and context. We talked about pain and symptom management, et cetera, et cetera. I do want to emphasize within those modules listed that we spent a tremendous amount of time focusing on communication, which was really wonderful. And we did this because there is such a lack of the appropriate access to needed medications that we wanted to ensure that communication skills were effective, that therapeutic listening and reflective practice were integrated so that the nurses saw communication as an intervention that could alleviate distress in and of itself over time. Each day, in addition to LNEC, we reviewed some of the international palliative care literature so the team could see what other global palliative care teams were doing in low resource settings. We did a scholarly writing workshop so the team felt comfortable in disseminating their work and their findings. One of the most enjoyable parts for me personally was daily work with self-care, so reflective practice, journaling, mindfulness, breathing. As we got to know each other and built relationships, I realized that almost everybody on the team had lived through civil war in Liberia. So here was this incredibly admirable, incredible group of community-based nurses who were going out to alleviate the suffering of others and yet had a significant history of trauma in their own lives. And so all of these self-care skills that we spend time with on a daily basis, many of them have continued them to date a year later, and it has led to more transparency and debriefing and processing the intensive work that they do. We also did an interdisciplinary team workshop with surgeons and physicians and architects and nurses. We did both the didactic portions and the self-care portions, and it really facilitated team bonding and an appreciation for the importance of palliative care integration. Here's just some photos of some of the topography that they're dealing with. The pictures with the palm trees are actually pictures from the PIH office in Harper. This was our working area and some of the nurses from the team. There were many other team members who came in and out throughout the week. All the nurses had a certificate of completion for their own accreditation and certificates that they could go on and provide other nurses for whoever completed the training at a later time. The response was really encouraging. We did a brief Likert scale evaluation along with free response. The free responses were really inspiring. Things like one nurse wrote, understanding that even in the absence of necessary resources, knowing that the way I communicate, my therapeutic presence is enough to alleviate distress and provide person-centered care is so encouraging. And you can see from the scores on the evaluation that people really felt very or extremely strong that the course content was relevant to their work, that they really found aid in discussions about the African and international palliative care reports, and that they found benefit from the self-care exercises. So we are continuing to sustain those partnerships. We are talking about how to provide additional training. PIH is talking about potential integration of the program into their NCD training globally across their 12 international sites. We're still in discussion about how that might work, and we're continuing to disseminate to help people understand what's going on in Liberia. Moving on to Rwanda, I'll talk briefly about the Human Resources for Health, the HRH program. So this was a 7-year capacity building initiative that was conceived by the Rwandan Minister of Health, Dr. Agnes Binagwaho at the time. And this was in partnership with a number of academic medical centers and schools of nursing, schools of public health and dentistry. And over 7 years, this program really wanted to increase the quantity of nurses and physicians, the quality of their preparation and training, and really decrease overall dependence on foreign aid. So we used a twinning model that paired us with local Rwandan colleagues for speedy knowledge exchange in a way that facilitated mutual benefit for both parties, for US-based faculty and Rwandan faculty. And I served as a clinical educator in the Rwandan Military Hospital in the ICU, and also as faculty at the University of Rwanda, where we were helping to create the first master's program for nursing in the country. In 2017, we graduated 110 students in 8 specialty tracks, and you can see some of our med-surg students at one of the Kigali referral hospitals, Sciatica, there on the right. So one of the things that we did in this program that colleagues of mine really led was in the pediatric track, where we led the first official integration of palliative care education into Rwandan nursing curricula. You can read more about that effort in the cited work at the bottom of the screen. That's also in the reference list. And within that course, they were able to really introduce the concept of palliative care, which was new to many of the students, concepts in pain and symptom management, palliative care around the time of death and into bereavement, the use of complementary therapies, which was very new in a severely resource-constrained setting. And there was a particular emphasis on transformational leadership. And we worked closely with Christian Natizamira, who partnered with us to emphasize interdisciplinary teamwork, but also the Rwandan context, which he's going to talk more about in a few minutes. In addition to education, we advanced palliative care research in Rwanda. We're lucky to have the co-PI of the study on the webinar. Hopefully you'll hear from her in the Q&A, Dr. Patricia Moreland from the University of Emory. Our aim with this study was to explore nurses and midwives, and as well as physicians, palliative care and end-of-life educational needs at 5 Rwandan hospitals. So we were looking at 3 referral and 2 district hospitals. We used a cross-sectional descriptive design, and we conducted that study between the spring and summer of 2017. You can see we had 420 participants, the vast majority of which were nurses and midwives, and they were providing care across several specialty areas. The primary measure we used was this end-of-life professional caregiver survey. So this survey is a self-report assessment of healthcare workers' self-perception of their knowledge and their self-efficacy with regards to palliative and end-of-life services. And the survey measures 6 different domains. So their scientific and clinical knowledge, their communication skills, their spiritual cultural issues, ethical and legal principles, organizational skills, and also the healthcare professionals' attitudes, values, and feelings. And we analyzed that survey using descriptive statistics and looked for differences between the groups using t-tests. So just over half of participants, we're currently writing up these findings, I should mention, just over half of the participants reported caring for patients at the end of life, and almost 90% said that they used palliative care methods. Now, interestingly, there were only 17 physicians in the study versus well over 248 nurses and midwives. However, physicians were much more likely to have received end-of-life training during education. However, only 39% of the sample actually received that training within the past 5 years. And again, you'll note huge variation in the actual length of training, anywhere from a day to more than 4 weeks. So that sustainability in terms of partnership aspect is really missing. And another interesting note was that there was no statistically significant difference in the scores between nurses and midwives and the physician group. However, when you look at the average scores of the groups, they tended to score lower on the Likert scale. So this was a 5-pointed Likert scale from 0 to 4, where 0 was no comfort with the competency and 4 was a lot of comfort with the competency. And the entire sample kind of scored in that 2 to 3 range on the lower end of the scale, with no significant difference between groups, as I mentioned. But their lowest mean scores were in resolving family conflicts, their knowledge of relevant cultural factors and how that translated to palliative care needs, their familiarity with hospice services, potentially because there are very few in Rwanda, and then feeling like they had the personal resources to meet the needs in caring for dying patients and their families. So we will be disseminating these findings. We have a number of ongoing collaborations and continue to seek opportunities to advance palliative care integration into a number of practice, education, research, and policy settings. I want to talk about Botswana briefly. So there is some emerging work in Botswana that's very helpful to this conversation on global palliative care. So Botswana as a country lacks a clear cancer control plan, and they have a very, very high cancer mortality rate due to a host of factors from poor screening to late presentation, et cetera. And there's a number of factors that impact the effective delivery of palliative care as well. The chronic shortages of medications, a lot of the other issues that are present in other low resource settings. There has been research that kind of shows that both the symptom burdens of patients in the community as well as spiritual and religious needs continue to go unmet, calling for more effective palliative care delivery. So there is a Botswana National Response to Cancer study that's a partnership between the Botswanan government, MOH, and Rutgers University here in the USA. And their aim is to conduct a comprehensive cancer needs assessment, really to strengthen capacity. And this includes the delivery of high quality palliative care. So my involvement with this has not been direct, but I'm a part of a pending grant where we're looking to better understand the palliative care learning needs of the Botswana workforce, as well as the experiences of cancer patients and their families, so that we can really drive palliative care capacity building in alignment with this broader parent study. And this call for the integration of palliative care across the trajectory of oncologic care is in alignment with the Lancet Oncology Commission report, as well as a number of other global reports. So I'll leave with this some of the important points of really the vision for global expansion of palliative care that I find important. One is, Dr. Cicely Saunders, who was the founder of the hospice movement and palliative care advocate, said that patients don't just need our competence, they need our compassion. And palliative care, to me, is an opportunity to breathe humanism back into the healthcare system. It is our opportunity to role model what the compassionate delivery of care looks like in the alleviation of suffering. We hope to integrate palliative care services further upstream in the disease trajectory to give time to build rapport, to build relationship, to make sure that care is value concordant for our patients so that they have an opportunity to improve the quality of their life and meet their goals. We do really have to dismantle these hierarchies in our biomedical model between professions, because ultimately it prevents us from delivering the seamless quality of care that we're all hoping to deliver. To advance research to support cost effectiveness models, particularly in low resource settings. We do definitely need more research on that. To ensure universal palliative access for all in alignment with what the WHO recommends, as well as the Lancet Commission on Pain Relief and Palliative Care, particularly morphine access for all. And to train healthcare workers in primary palliative care skills, to remind them that they are frontline primary palliative care delivery clinicians, that their effective communication, their ethical care planning, their timely pain relief, their ability to identify patients in need of specialty consultation is just critical to expanding global palliative care access. So with that, I'm going to say thank you, and I'm going to pass it over to Christian Natizamira, who's going to go deeper into the case study in Rwanda.
Thank you, Billy, and thank you, Nozli, for the great presentation. So I'm going to share the case study of Rwanda and how we can value our expertise by experiences. Why? Because local is global as global is local. I would like just to remind us that treating the patient and treating the disease is, from my understanding and from my experiences, is two different concepts. Because if you can treat the patient, you are pretty sure that you will treat also the disease, but you can treat the disease and missing treating the patient. So it's really important to understand, on my perspective, that different the patient and the disease has to be matching, or has to be the from my experiences is totally different. So back in Rwanda, so Rwanda it's among the smallest country in Africa, not a small nations, with almost 12 million people and 4% of our population living in the rural area. And as you may see, we still have challenging in terms of patient, physician, the ratio between physician and patients. So this is now more than 25 years after the genocide against the Tutsi, where we have 1 million people died in 100 days. It's not only 1 million people died during the genocide, but our humanity itself seems low during that period. And my understanding is the concept of palliative care will bring back that sense of humanity we lost and during the genocide, and the concept of palliative will contribute a lot. Why? Because when you're talking about palliative care, it's not about death and dying. It's about dignity, humanity, and build the sense of community. But since the last 25 years, so many things have been done in Rwanda, and Rwanda rose up from ashes in terms of maternal mortality in the country, child mortality from 1990 until now, access to IRTs for adults and children. And as you may see, the life expectancy in Rwanda in 1994 was around 20 years old, and which is now moved above 65 years old. How was the background of palliative care beginning in Rwanda? So one of the studies made by the Penn Policy Study Group from the University of Wisconsin showed that around more than 60,000 patients with HIV and cancer died with moderate and severe pain. So the morphine equivalent at that time was only 0.2 kilogram. And you can imagine 0.2 kilogram was just enough to treat 27 people. So an estimation of patients who are suffering from pain was even more than 85%, which was one of the really challenge that time where the country was facing in terms of treating the pain. And also the opophobia, the fear of using opioids, is one of the common challenges we have in developing countries. And also the doctor's attitude regarding pain. And I remember one of our my colleague used to tell me that you cannot treat the pain totally, because if you treat pain, how can you know that the patient will still alive? So don't treat pain totally, because that will be the signal to show that the patient is still alive. And that time also the protocol was really nightmare. If you want to use just to prescribe 1 amp of morphine, you need a red ink and 3 signatures from the pharmacist, clinical director, and maybe the medical director, which is really a nightmare if you need more than 1 amp. The restriction for governing the laws for governing use of narcotics was also one of the challenges. As I mentioned, all opioids are imported except morphine reconstitutions in the countries, and also some bureaucracies between people from the pharmacy, the district pharmacy, and the physician about what is really the quantity we'll be using and how the consumption will be reporting was also was among the challenges. Lack of knowledge in pain assessment and management, of course, among physicians. My personal story also was how I get to palliative care. So my dream after the medical school was to be one of the best surgeons. And I thought that to be a surgeon, I will contribute more within the country. And until I met a very young guy, 24 years old, who was really dying in liver cancer. It was in Kibagabaga. I was doing a road round and I saw this guy, he was really dying in pain. And the worst part of the story is his mom came to me and kneeled before me. He asked in our mother tongue in Rwanda and said, please, can you just prescribe something for him? Then he can sleep and wake up no more. I was really shocked by that. And especially in our context, when you have an elder person kneel before a young person, that means you failed. So I failed twice. I failed as a physician because I couldn't prescribe opioid for this young person, and also I failed culturally because that person, that elder person who kneel before me, was really for me a fail. So I questioned myself when I went back home, why am I spend so many years? Why did I spend so many years in medical school if I cannot even really spend? So I shifted completely, and I found that there is a need to bridge the gaps as a physician, but also as a human for those people who really need support. So how to reach the unreachable? One, what the government did, so in 2011, the Ministry of Health in Rwanda launched the first standalone palliative care policy, strategic plan, and implementation plan. So, and Rwanda became the first African country to have a standalone policy and a strategic plan. This has changed completely the platform how physicians can use and prescribe morphine, how the concept of palliative care will be integrated in public health system, and also integration. There is no, my understanding is there is no clear equity without an integration. Because if the program is really integrated in public health system, so the whole channel, the whole public health system, the patients at each level will benefit for for the services. So, so it's why my understanding when we talk about palliative care as universal health coverage, so integration is really part of that, because integration is really equity. And the public health system in Rwanda, from the district health centers, and now we have home-based care practitioners in villages who will be supporting patients at all levels, and the whole package of palliative care has been defined by the Ministry of Health. So when we talk also about community, it's about also social justice, and the government of Rwanda now targeting to hire more than 1,000 palliative care, home-based care practitioners who will be providing services at the community level. So treat the pain and relieve suffering. And as I mentioned, and Nosley talking about the challenge we have in developing countries access to morphine. So the Ministry of Health decided to produce its own liquid morphine, and the morphine powder is now reconstituted in Rwanda since November 2014, and it's really free for all patients in a palliative care program. And you can see the change when you have a very good education program for physicians. When you educate the physician and the multidisciplinary team, we have a strong policy, and it's really integration in the public health system. So for us, it's an evidence base that everything changed completely. So we moved from 0.2 kilogram, and which is now up to 10 kilogram. And as the Rwanda now needs 97 kilogram according to the pain policy study group. So we hope in the future, by continuing training physicians, nurses, and all the multidisciplinary team, we'll be able to address the issue, and also we'll be able to get our target when we have pain-free for all patients in moderate and severe pain. And local is global as global is local. And recently, the newspaper for Associated Press mentioned that the way the model of Rwanda was using could be a model which can inspire many countries at local international level, and maybe to avoid opioid crisis, and make those patients not to be victimized by the opiophobia, but at least to get access to opioid for those who really need opioid, but also have a security way, a safety way how morphine will be used. Supply chain is not just a system, but it's also a supply of hope. And from the Ministry of Health, you can see how when morphine is reconstituted at the central level, is sharing at the district pharmacies and at the referral and province hospitals, go to the district hospitals and health center, community health workers, health posters. So it's really clear that the supply chain, how the supply chain has been reviewed by the Ministry of Health to make access to morphine to every patient who really suffer from moderate and severe pain. It's also a supply of hope. It's not just increasing or improving the system, but it's also a bring hope for patients and their family. The tax shifting from the previous experiences in HIV/AIDS and tuberculosis pushed also the government to review the law in 2012, the law governing narcotic drugs, psychotropic substances, and the precursor in Rwanda, which now allow nurses and all clinical officers to prescribe, trained, of course, to prescribe opioid, which is a really big step in Rwanda. And the previous experiences show us that we need to alleviate pain, but also we need to empower and invest in people, and nurses, which is now the year, according to the WHO, the year for nurses, need to be empowered, not only on other disciplines, but especially in palliative care. So the model of Rwanda in palliative care is really comprehensive, from the policy to the monitoring, evaluation, different multi-sectorial partnerships, drug availability, procurement, and distributions. So this is the model using in Rwanda, very comprehensive and very inclusive to make sure that patient and family at the community level, at each level of the system, will get access to the services. So why culture matters? We need to understand the current model of end-of-life care, advanced care planning, and decision-making are grown out from Europe and American clinical and cultural experiences. So, and sometimes it's really difficult to understand based on a different context, based on a very good willing for partners, but you know, the context matters. It's totally different. The way people think, the way people react, how they think about what is the philosophy of life, the philosophy of death is totally different. So the system had to be adapted based on the local context. And my experience is traveling in Europe and America. I understood that patient autonomy, it's one thing very important on the context. And I understand that education doesn't mean necessarily duplication, but rather adaptation. And understand also the Rwanda social context is very important. And I've learned on my practice that in Rwanda, when you are well, you belong to yourself, but when you are sick, you belong to your family. So it's not only about patient autonomy, it's patient autonomy and community responsibility. So there is intersection, a very good balance between the need and the expectation from the patient and also the responsibility from the community. The role of family members, of course, is really crucial, and it's really important to understand that the community, the family members are playing a very crucial role in palliative care. And understand that we have a very strong rooted African philosophy called Ubuntu. Ubuntu, it's understanding resources beyond funding, because most of the model care developed in Africa is finance-based, and when there is finance withdrawal, some of the programs stopped, and we need to root it to our philosophy called Ubuntu, and in Kinyarwanda it's Ubumonu, which means people are people through other people. So we don't define, and I understand that we don't define as an isolated person, but we define as a soul. So it's about humanness, caring, sharing, respect, compassion. And one of the quotes from my patient, he told me that when people are everything, man is nothing. So culture matters in terms of personhood, family values, disease and the illnesses. Understand that from a Western approach and the African perspective, we can have a similarity, but it's totally different. And we need to take patients in sense of pain, death, and bereavement according to its environment, according to the context, if we really need to provide a very good palliative care services. And my understanding, let's say my experiences for the last years practicing palliative care, I understood that the way people die can reflect how the society lives. So if I really want to understand about society, the patient society, if really I want to understand the environment of the patient and family members, if I'm following a patient during the dying process, if I'm following a patient from the diagnosis to end of life care and bereavement with the family members, are really, from my experiences, is that perspective period, I will really understand what is the reflection. I can get all sense of emotion, feelings came from the patient and the family members, and understand well how their society, how they define a society, what is really ethical, what is respected, what is important, what is crucial, what is necessary and unnecessary. And I remember when I was following a patient, this lady with HIV/AIDS and the cervical cancer, we find at home with our nurse piece. And when I saw a lot of need, I just sat down and I feel naked. Yes, I feel naked, to the all they need isophodate patient. So and just remember that I felt naked to not be able to help the patient diagnosed with liver cancer who died in imaginary pain because I feared to prescribe morphine. I felt naked when his mom kneeled before me and asked something which helped her son to sleep and wake up no more. I felt naked because I felt twice as a physician, as a Rwandan, blamed by my ignorance, fear, and shame. I feel naked when I see many patients are still dying with horrible pain in the hospitals at home because they couldn't get access to strong opioids. I feel naked when people call me a grave digger because they are wondering why I'm taking care of those who are already condemned. I feel naked when I see my colleague cannot prescribe a simple dose of morphine to patients suffering with severe and moderate and severe pain because of myth. I feel naked when I see family members and caregivers helpless and hopeless to support the patient and their wish. I feel naked today when I'm visiting patients. I see social psychology and spiritual pain, and I don't know how to help. I feel naked when dignity and sense of humanity of the patient are affected because of the incurable disease. I feel naked when I see the quality of life of care depend which part of the world you belong. I feel naked when people are happy to publish data from low middle income countries, but less to support those countries they show the data. I feel naked and sad when colleagues from developed country mention that you are not doing, what you are doing is not palliative care, despite the limited resources and effort to support patients. I always feel naked when I read on the eyes of my patient an expression of our gratitude, satisfaction, and hope, just because we are there. But I'm not ashamed because I cannot do everything, but I must do anything. So my conclusion is really simple. In Africa, the model of care in palliative care should consider the social context, the cultural values, and the local perception of death and dying from the patient and family members. Because care delivery is one thing, and the perceptions and care it's another point. So I would like to acknowledge the Ministry of Health and all partners really involved in Rwanda to develop the palliative care program. I would like now to reintroduce Nozli for Q&A. Thank you.
Thank you, Christian, and thank you, Billy, for your fabulous talks and for and also sharing your vulnerability with us, since palliative care can be very vulnerable work. I think we have a few questions lined up. And just before we do that, I just want to say that please feel free to contact any of us individually if we don't have time to get to all of your questions. And if you have specific questions about our working group and getting involved, you can certainly reach out to me directly. Now I will start with just a question that was directed towards everyone, which is specifically around how much training is required to allow nurses to feel comfortable and confident in managing most palliative patients, including initial assessment through treatment planning and prescribing, including opioids. And I think maybe Billy, you can start with this one, and then Christian, you can fill in how your experience has been as well.
Sure. I think from my perspective, I think it really varies on the system and how the system utilizes nurses to the extent of their training and capacity. So I think it varies based on what is the depth of familiarity with palliative care within the system. So is it a system that is actively treating symptoms, that is referring to hospices, that has those services available, where there are control mechanisms for narcotics, et cetera. It does depend on the hierarchy within the model. Our nurse is a respected team member, where I can tell you it's not just about the training. So a lot of nurses I work with in different parts of the world feel very competent with medication dosages and titration and would feel competent to prescribe, I feel. However, the hierarchy is such that if a physician is in the room, they will not speak or recommend when the physician is in the room because the hierarchy is so constraining. And I know Christian can speak to that as well. So some of it is just about the hierarchy and the culture. And also a part of that question that sticks out is what we mean by a palliative patient. So from my perspective, there is no quote unquote palliative patient. There are patients who confront chronic illness and serious illness where palliative care skills are called for. So I think as long as we're empowering nurses with even basic training in primary palliative care skills of effective communication and identifying when specialty consultation is required, then those are foundational skills that can be used in any setting.
Wonderful. Anything
Yeah,
to
I think I think what Billy said, I totally agree with. He said, and my perspective is like we sometimes some terminology can stigmatize our patient and family. Like in cancer, people say, "Oh, it's a cancer patient." I think it's a patient with the cancer, so we need to really bring back this sense of humanity and dignity to our patient. And also empower nurses. I think this can make a change.
Great. A couple of questions that I'm going to actually lump together is around, I think, pertaining to the interdisciplinary team. So one of the questions was, do you involve traditional faith healers in this work? And another was, do you have suggestions around integrating psychologists or other key players into this work? Maybe I will have Christian start with this one around, I think it has to do with some of the task shifting that you talked about.
Yeah, so the experiences we had even for traditional healers at the Ministry of Health, there is a desk now for traditional healers, but because the Ministry of Health find that most of patient and family members, when they have symptoms, they go directly for traditional leaders as they're on the front line. So it was really imperative for the government of Rwanda to train traditional healers and work closely with the government. So in that sense, even for traditional spiritual in every traditional way, we need to create that synergy because it's really important for patients if they think that the ancestors are really involved on the condition and if they need even peace, because when we talk about spirituality, it's not about religion, because every patient is spiritual, but every patient is not religion. So it's in that context we are working with the government, and there is a clear synergy on that sense.
Great. And I really appreciate all the wonderful questions that are coming through. I do worry we won't have time to answer all of them. So again, encouraging you to reach out to us individually if we don't get to your question. But the next question is around support and for family members. And I imagine bereavement support being part of this. How does that look in the respective settings that both of you have worked in terms of integrating the family members?
Yeah, for from the experiences from Rwanda, when we admitted patients, we called the family members meeting, and as you can imagine, it's not one person, two persons. Why? Because it's the whole community. As I said, we define ourselves as a soul. So we normally the meeting is around 15, 20 people because that person is really connected with this community, and our role is to making sure that we will share the good information, how we can support the patients, but also in the sense, our role also is to identify who is the lion of the group, because in terms of decision making, we needed to clarify that we need to work closely with the patient, but also making sure the community responsibility will be neglected. And in that context, we created another platform of discussion, not with 2 or 3 people, but with 15 people. And the advantage of that is you speak with 15 people in the morning and you have the whole village know about palliative care.
And I do want to emphasize that I know in Liberia, being community-based, the whole relationship and support of the family was just pivotal to gaining community entry. And they have a story about the cola nut, this fruit from the cola tree that consists of caffeine. It's bitter, but it's used to represent a ceremonial welcome. So this team getting to a place where the drink was actually offered to them from the community as a sign of acceptance and welcoming. It was just a huge bonding with the community and with the family, and represented long-term relationships. So, in a lot of the settings that I discussed, family and community buy-in and partnership is just critical to actually being able to deliver palliative care from diagnosis into the bereavement period.
Wonderful. Well, thank you again both for sharing your expertise with us. Unfortunately, we are out of time. I really want to thank all of our listeners and specifically the folks who sent in really thoughtful questions, which I'm sorry we couldn't get to all of them, but please, please, please reach out to any of us individually. And someone had asked, are these slides going to be made available? And they will, through the CUGH group. They will be planning to actually share the recording of this talk. We really appreciate all of your support and your attention during this webinar.